This is a brief video on breast pathology. In this video, we're going to be talking about neoplastic and non-neoplastic diseases of the breast in females. We have a list of the diseases we're going to talk about across the left there. The first several are all benign conditions of the breast, and the last 5 are malignant conditions of the breast. Now, I specify that this is a video on diseases of the breast in females because I'm not going to be talking about gynecomastia, which is one of the more common breast conditions in men. Of course, gynecomastia is the norm in females, so we're not going to be talking about that here. Also wanted to note that some of those benign conditions are non-neoplastic. Some of them are inflammatory, like acute mastitis, periductal mastitis, fat necrosis, mammary duct ectasia. So those are benign conditions, meaning non-malignant. They are not necessarily neoplastic. And on the image on the right here, we have a picture of 2 kinds of malignant conditions. We have the localized DCIS, that's the ductal carcinoma in situ, and then we have what happens when that DCIS breaks through the basement membrane, and you have invasive cancer or invasive ductal carcinoma shown on the bottom there. So let's start jumping into these conditions. First, we have fibroadenoma. This is a non-cancerous breast tumor consisting of stromal and epithelial tissues, specifically overproduction of the stromal tissues. Epidemiology is that this is women premenopausal, so 20s to 30s of age, and this is the most common benign neoplasm. That's fibroadenoma, the most common benign neoplasm. Clinically, you see a painless, firm, rubbery, mobile lump. This lump is estrogen sensitive, so it might enlarge based on where you are in the menstrual cycle. Grossly, on pathology, you see a solid lobulated mass that is tan and pink in color and is firm with no necroses. There should be no hemorrhage, and this mass should be well circumscribed. On ultrasound, you could see a solid, round, homogeneous mass that's also well circumscribed on ultrasound. You'll see a picture of that in a second. And on histology, we see the gland structures that are characteristic of the breast with stromal and ductal proliferation. There should be no cytologic atypia. Because no cytologic atypia, that's a hint that these have no malignant potential. They're benign breast tumors. Treatment here is to excise these surgically if they bother you. So here's a picture of histology on the right, where we see the gland structures that are characteristic of the breast, and we also see a lot of stromal and ductal proliferation. There should be no cytologic atypia here. At the top, we have an ultrasound picture showing a solid, round, homogeneous mass, and that's a fibroadenoma. Next tumor is Phyllodes tumor. This is also known as a cystosarcoma Phyllodes. Definition here is that it's a mass arising from the stromal cells surrounding the ducts of the breast. So this is coming from the stromal cells. It's fibrous and it's going to be pushing out on the breast. And that pushing out action is going to lead to the changes that you see on gross and histologic pathology. So fibrous neoplasia that pushes out the tissue. Epidemiology is that this is older women than the fibroadenoma. This is 40 years of age or more, plus postmenopausal women, particularly common in African Americans, but otherwise it's a pretty rare tumor. Clinically, we see a large mass, bulky, mobile, firm, very firm, often described as a wooden log consistency. It's twice as large as the other breast tumors that we talked about. So it makes one breast look twice as large as the other. It really shows some asymmetry there, and that's the fibrous neoplasia that's pushing out the tissue in the Phyllodes tumor. Grossly, we see blue veins on the skin surrounding the tumor. Again, that's the pushing out effect from the fibrous neoplasia, and it should be well circumscribed. On histology, we see fibrous glands and tissues with intermittent cystic spaces. We see epithelial leaf-lined structure. It's often described that way, leaf-lined, and we'll see a picture of that in a second. We see cytologic atypia, and mitotic figures should be rare. So the atypia and mitotic figures are not common here, and that's another hint that this is a benign condition. This one does have a better chance to spread than the fibroadenoma. Something like 5 to 10% undergo malignant potential, and for that reason, the treatment is to excise surgically, either a wide local excision or a total mastectomy. So this is the leaf-like structures that you see on histology on the right there. You should not see cytologic atypia and mitotic figures, although it might be rare. You also see the fibrous neoplasia on ultrasound pushing out through the tissue. Excuse me, that's a mammogram, not an ultrasound. You see the fibrous neoplasia pushing out on the tissue. Next is fat necrosis. These are also called fatty lumps of the breast. These are normal fat cells of the breast that become round lumps through necrosis. These are usually caused by trauma, radiation, or surgery, so some kind of damage involving the breast causing the fat tissue to necrose, and it leaves you with a lump called fat necrosis. Epidemiology here is any woman that has undergone trauma, radiation, or surgery. Clinically, these are painful. You feel induration with irregular contours, and there's also retraction of the skin as a result. On mammogram, you see eggshell calcification. This is a result of the saponification reaction that undergoes in fat necrosis. That's the fatty acids that are interacting with the calcium, and it leads to a calcification around the fat necrosis region. Grossly, you see necrotic fat tissue. You do have to biopsy this to rule out cancer. You also see like an induration of tissue on gross pathology. Histologically, again, you see necrotic fat. You see calcifications on histology sometimes. You could also see giant cells, granulation tissue, and lipid-laden macrophages, all things that make sense with the saponification and the fat necrosis reaction. There's no malignant potential to these, although they do resemble some cancers, so you do have to biopsy to rule out cancer. So again, confused with cancer because of calcifications, induration, skin retraction, and irregular contours. Treatment is not necessary. They can be removed surgically if desired. So this is the necrotic fat with calcifications. On histology, you can see these white globs are all fat, are all necrotic fat and lipid-laden macrophages. Next up is acute mastitis. This is a bacterial infection of the breast. It's typically caused by skin organisms like Staph aureus or some streptococci. This is usually caused by breastfeeding, where the infant places stress on the skin that allows this bacteria to enter the breast. So epidemiology here is women that have been breastfeeding. Clinically, you see a purulent, pus-filled discharge from the breast. The breast is usually warm and erythematous, and you usually lose a bit of nipple integrity there as well. Grossly, you might see an abscess form, especially if they're not treated. There's no malignant potential to these. This is an inflammatory condition, not a neoplastic condition. Treatment here is antibiotic. If it is a Staph aureus infection, you specifically want to use dicloxacillin, and you do want to keep draining the breast, usually by breastfeeding, to ensure that it does not form an abscess. Next is periductal mastitis. Definition here is that this is inflammation of the breast tissue directly beneath the nipple. This is usually caused by smoking. Now, smoking leads to a vitamin A deficiency, which prevents you from maintaining the specialized epithelium at the subareolar duct entrance. This leads to an excess production of squamous epithelium, which is unusual. You normally want to produce columnar epithelium in these ducts, and the duct then gets clogged with the squamous epithelium. Inflammation happens behind the clog, and oftentimes there's fibroblastic activity involved in that inflammation. That fibroblastic activity can then cause scarring, and that contributes to some of the physical manifestations that we see. So as we said, this whole pathophysiologic process starts with smokers, so the epidemiology is smokers. Clinically, we see a subareolar mass and nipple retraction. I like to think of the nipple retraction as happening from the scarring that happens beneath the nipple. Next is mammary duct ectasia, also called duct ectasia of the breast or plasma cell mastitis. Plasma cell is a big hint here. Definition here is that the lactiferous ducts become blocked or clogged. This is just standard inflammation of the ducts that leads to duct dilation. Debris piles up into the nipple, and that debris is then released from the nipple as discharge. This usually happens in post-menopausal women or women that have had many children, multiparous women. It's usually pretty rare. Clinically, you see a green-brown nipple discharge. That's pretty characteristic of mammary duct ectasia. On mammogram, you do see rod-like calcifications, and on histology, you see plasma cells, hence the other name, plasma cell mastitis. Next is fibrocystic changes, which is a group of collective changes that happen in the breast, also called fibrocystic breasts or fibrocystic breast condition. This is an appearance of cysts and fibrous tissue in the breasts, just as the name implies, fibrocystic changes, fibrous tissue and cysts in the breasts. Epidemiology here is that this is premenopausal women, so 30 to 55 years old. It's a pretty common condition. This is also a painful condition clinically. There are bilateral breast masses. It usually happens in both. The breasts can be lumpy, especially in the upper outer quadrant, which is the region of the breast where you have the most tissue. The pain is often cyclic with hormones, so this is another hormone-mediated process. Grossly on pathology, you see cysts of various size surrounded by dense fibrotic tissue. This usually leads to a blue-domed cysts appearance, and that's a characteristic description for the fibrocystic changes. On histology, there are several variants. You might see proliferative changes, which include ductal hyperplasia and sclerosing metaplasia. You might also see non-proliferative changes, which are cysts with dilation, fibrosis, apocrine metaplasia, and calcification. Of course, these proliferative changes are they predispose you to a higher risk for malignant changes in the future. The non-proliferative changes are usually a bit more benign. So usually no malignant potential. The proliferative changes might be a little more concerning. Treatment here is oral contraceptives to manage your symptoms, since they are kind of dependent on the hormones. Next is intraductal papilloma. This is a benign breast lesion occurring with lactiferous ducts. Happens in premenopausal women. Clinically, you see a bloody nipple discharge. This is the most common cause of bloody nipple discharge. There's no pain associated with these, and it could just be a small lump or clear discharge as well. So you don't always see a big lump on the breast, and you don't always see the blood, although this is the most common cause of bloody nipple discharge. Radiographically on mammogram, you see dilated ducts with intraluminal filling defects. On histology, you see characteristic fronds with a fibrovascular core. That gives rise to the name papilloma. It has a papillary appearance. So you see these fronds, and it's important to know that these fronds have both an epithelial cell and a myoepithelial cell surrounding the ducts. And this is what ensures that we know that this is a benign breast lesion. If it was a malignant condition, if it was a carcinoma, we might be lacking the myoepithelial cells. So if we do have bloody nipple discharge, we do want to look for both the epithelial and the myoepithelial cells on histology. We can do stains for those, and that reassures us that it's a benign condition. So there's a minimal risk for cancer here. Treatment is to remove the affected ducts in intraductal papilloma. Now here you can see the fronds that have a fibrovascular core. It's important to see that pink core, and that tells you that it's an extension of the tissue. And if you were to stain these for myoepithelial and epithelial cells, you should be able to see both because it's a benign condition, intraductal papilloma. Next is ductal carcinoma in situ. This is the first of the malignant conditions. This is also called DCIS for short. This is a pre-invasive cancer of the breast in the ductal lumen. So you can see that in the picture there. This is pretty much confined to the ductal lumen. Has not broken through that basement membrane yet, but it still shows some malignant signs, some cytologic atypia on histology. So again, does not break through the basement membrane or myoepithelial cells, not yet. Histology, there are several subtypes. The one that's most important to know is the comitocarcinoma, where you see a central region of high-grade necrosis. You also see calcifications that are linear and branching on mammography related to comitonecrosis. That's worth being able to recognize as well. Linear and branching calcifications. So on histology for the comitocarcinoma, again, you see a dark calcification region. This calcification region is usually surrounded by necrosis, so calcification happens in the middle of the necrotic region, and around the necrosis are the rest of the neoplastic cells that have some cytologic atypia, some other indication of being malignant neoplastic cells. Another subtype is the solid variant, in which the cancer fills and stretches the ducts. There's a cribiform variant, in which a Robin bridge glandular pattern can be seen. A micropapillary subtype, in which the tubes emanate from a single epithelial layer, and a papillary subtype, in which intraductal proliferation with fibrovascular components can be seen. But again, I think the most important to recognize is the comitocarcinoma, with those three layers, the dark calcification surrounded by necrotic region, surrounded by malignant neoplastic cells. These are usually not palpable clinically, and again, you do see calcifications. If it's the comitocarcinoma type, you see linear and branched calcifications on mammography. High potential for spread. This is pretty much a cancer that's in position, that's in situ. So it's definitely a precursor to invasive carcinoma. Treatment is the works. So you have surgery, probably going to add some hormone therapy, probably going to add some radiation to that as well. Next up is Paget's disease of the breast. This is essentially when DCIS spreads to the areola or the nipple. Clinically, you see nipple ulceration. You can see eczema, redness, and swelling of the nipple as well. So on histology, you see single cells with an abundant pale cytoplasm. This is pretty characteristic of Paget's disease of the breast and also Paget's disease of the vulva. You see atypical nuclei and small nests of these cells that are infiltrating up into the skin epidermis toward the outside of the body through the nipple. The spread here is that you have a high potential for spread. When you see Paget's disease of the nipple, there's a very likely chance that there's some kind of carcinoma underlying that Paget's disease of the nipple. So usually DCIS underlying the Paget's disease. Treatment here is surgery, chemo, and radiation. So here's an image of Paget's disease in the nipple. I'm going to point out some of the pale cells that you can see here. These are the pale cells that are working their way toward the outside of the body in Paget's disease. So histo says single cells with abundant pale cytoplasm, atypical nuclei. These are working their way up to the epidermis, characteristic of Paget's disease. On clinical signs, you can see nipple ulceration, eczema, redness, and swelling, as shown in that picture. Next disease is invasive ductal carcinoma. This is a cancer of the breast that has spread out of the ducts through the basement membrane and myoepithelial cells. So this is like a DCIS that has spread through the basement membrane. Pathophysiology, histology, and prognosis are all based on the subtypes of IDC. There's a tubular subtype that has a pretty good prognosis. You see tubules on histology. There's a mucinous subtype that in which you see cancer cells in a pool of mucin, and a big glob of mucin also has a good prognosis. There's an inflammatory subtype that has a worse prognosis. This is the characteristic peau d'orange, or the orange peel appearance, in which breasts are very swollen and look like an orange peel. This is an inflammatory condition. It's usually caused by clogging of the lymphatic vessels, which causes inflammation upstream of those lymphatic vessels. So the lymphatic vessels get clogged up with the cancer cells, with the malignant cells, and there's inflammation upstream that gives it an orange peel appearance. There's a medullary subtype in which high-grade malignant cells with inflammatory lymphocytes and plasma cells can be seen on histology. This also has a poor prognosis. And this is the one that's usually associated with the BRCA1 genes. Clinically, these invasive ductal carcinomas can be firm, palpable masses, but you might not see a mass at all. It could be occult. You might see skin dimpling. You might see nipple retraction. So that was a reason to kind of differentiate nipple retraction from the periductal mastitis, the previous condition we talked about that also showed nipple retraction. And that was concerning for a carcinoma, and this is that carcinoma. On mammography, you see calcifications with a stellate density. It's a star-like projections. Grossly, you see a spiculated mass, also star-like with projections, tan white in color with ill-defined borders, characteristic of cancer. On histology, you see glands breaking through the basement membrane and myoepithelial cells. These glands are usually surrounded by desmoplastic host stroma, usually characteristic of any neoplastic condition. Treatment, again, is the work: surgery, chemo, radiation, and hormone therapy. Next is lobular neoplasia. This is a pre-invasive cancer of the lobule unit. So we talked about a pre-invasive cancer of the ducts, that was DCIS. This is kind of the same thing, but for the lobules, deeper into the anatomy of the breast. And you can kind of see this would be a lobular in situ carcinoma, whereas this, a ductal, a DCIS, would be in this region of the duct. So this, again, does not break the basement membrane, not yet. It's subdivided into atypical lobular hyperplasia and lobular carcinoma in situ. So this is based on the involvement of the lobules. How many of the lobules have this lobular neoplasia in them? If it's more than 50%, then it's considered LCIS. Clinically, you don't see a mass, you don't see a calcification. This is usually an incidental finding. You're usually doing a mammogram or looking at the breast for another reason where you see lobular neoplasia. Grossly, this is usually bilateral and usually multifocal. On histology, you see loose intercellular connections. This is because the cells are lacking E-cadherin, which is a protein that allows cells to adhere together. So the intercellular connections are loose, and you also see proliferation of low-grade tumor cells in the lobules. This is definitely associated with the increased risk of breast cancer, specifically invasive lobular carcinoma, as we'll talk about next. Treatment here is to treat medically, usually with a selective estrogen receptor modulator, specifically tamoxifen, which is an antagonist in the breast tissue. You don't want to do surgery just yet, but you do want to watch your patients carefully. And lastly, you have invasive lobular carcinoma. This is a cancer of the breast that has spread out of the lobules, so kind of that LCIS, or lobular neoplasia, that breaks through the basement membrane and through the myoepithelial cells and spreads that way. It's invading the rest of the breast. Clinically, you see metastases to unusual sites, like the gynecologic tract, the GI tract. This is pretty occult compared to invasive ductal carcinoma. So again, LCIS was found usually on incidental findings. This one is also the resultant invasive lobular carcinoma is usually also occult compared to the DCIS and IDC variant. Grossly, you see bilateral multicentric lesions. On histology, you see linear or single file arrangements of tumor cells. This is again because these cells are lacking E-cadherin, just like in LCIS, just like in lobular neoplasia. So if they cannot adhere together, they usually form a single file arrangement as opposed to the normal glandular roundish appearance. You see low nuclear grade and usually a lack of desmoplastic stromal response. Treatment here is, again, everything you can throw at it: surgery, chemo, radiation, and hormone therapy based on the receptors that the carcinoma has. If it has estrogen receptors, you might use an estrogen inhibitor. If it has progesterone receptors, use a progesterone inhibitor. HER2 is another receptor that's important to look at to see what kind of hormone therapy can be used to help prevent the spread of this cancer. And again, this is just a picture of the histology of invasive lobular carcinoma with a characteristic linear or single file arrangement of the tumor cells. So you can see several lines of these tumor cells. And again, this is because these cells lack E-cadherin, a protein that allows them to adhere together in that normal glandular formation. So this is histology of invasive lobular carcinoma. This has been a video on breast pathology in females. I hope this was helpful, and thank you for listening.